not only are you seeing more and more providers drop certain plans, but you're also starting to see plans starting to pull out of markets. The system is getting frayed on both ends.
Welcome to the Business of Healthcare podcast. From the Center for Healthcare Leadership and Management at the University of Texas at Dallas, Naveen Jindal School of Management. Here at UT Dallas, we bring together business heads and other thought leaders to help navigate the challenges of our rapidly changing, increasingly complex healthcare ecosystem. I'm your host, Professor Dan Karnuta, Director of the UT Dallas Professional Program in Healthcare Management. Be sure to subscribe on Apple Podcasts, Spotify, or your favorite podcasting app to ensure you don't miss any future episodes. You can also join us online at businessofhealthcarepodcast.com. In today's episode, we're going to be talking about Medicare Advantage, which we've labeled the collision of Medicare and managed care. So to start out with, get into your time machine, and we'll start this episode back in 1965 when the U.S. passed into law a healthcare program designed to primarily cover seniors, 65 years old and over. This was a big move for our country, whose government is designed to move in slow, calculated steps. You see, Medicare had to be funded, and that funding would come primarily from taxes. So as healthcare costs in the U.S. continued to rise at a level that outpaced general inflation, meaning healthcare costs were growing faster than just about everything else, it attracted not only the attention of patients and employers who directly funded those costs, but also the U.S. government, which was funding a significant amount of healthcare cost growth with our money, our taxes. In fact, the U.S. spends far more per capita and as a percentage of gross domestic product than any other developed country on healthcare, yet by most accounts, our health status and life expectancy does not justify that higher spend. As the government, in this case specifically the Center for Medicare and Medicaid Services, or CMS, looked for ways to try to slow the pace of healthcare cost growth, it turned to a concept known as managed care, which eventually would turn into what we know today as Medicare Part C or Medicare Advantage. To help us try to better understand this somewhat confusing part of our Medicare system, our guests today are Lawrence Laddaga, founder of Laddaga-Garrett, PA, based in Charleston, South Carolina, and Dale Turner, an attorney in his firm. Lawrence, Dale, welcome to the podcast.
Thank you, Dan. We're happy to be here. Thanks for inviting us.
Thank you for having us.
Can you guys start by telling us a bit about your firm and how you became focused in the healthcare sector?
I started practicing in 1981 and actually started out as an estate tax lawyer and then moved into general commercial collection work. The firm I was with at the time was representing an HCA facility that was getting a certificate of need, and I met the CFO, and he sent a case involving a car wreck case, which we handled, and then that went well, and within a year I had 25 files, and then joined the HFMA, the Healthcare Financial Managers Association, and within another year had a number of hospitals. And so I kind of fell into it by accident, but I've done it almost exclusively for the last 40 years. And where our focus is on the appeals of denied claims. So that might be managed care, private insurance, group insurance, Medicare, Medicare Advantage, Medicaid, some workers' comp.
So what exactly is managed care in layman term, and how did CMS get Medicare into the managed care business?
So prior to managed care, you just had health insurance. After World War II, when all the vets came back from overseas, there was a fair amount of competition for talent among businesses and looking for inexpensive ways to supply additional employee benefits. Insurance companies started offering health insurance and employers started paying for it because when it started, it was a very low cost per member per month. And the larger the employer, the more employees, the smaller the cost is. And when it started, most health insurance policies had the same terms, read the same. So if, Blue Cross Blue Shield had a reasonable and customary charge requirement to pay a bill, they all had that. And as you mentioned, healthcare costs historically have outpaced inflation pretty much every year since. And so in, I want to say, the mid 70s, there was the statutory creation of HMOs, health maintenance organizations, which is basically a statutory entity in which one doctor serves as a gatekeeper, your primary care doc, and that in order to see a specialist, you'd have to have a referral, which was one method to contain costs. And then eventually, health insurance companies started entering into contracts directly with providers where they would agree upon rates that were favorable to the providers and acceptable to the health plans, health insurance companies, but also provided some mechanisms to control costs. In my opinion, I think the industry paid more attention to the rates in the beginning and not enough attention on the provisions in the contract that were meant to control costs. But the idea of payers contracting directly with providers probably took fire in California and some of the larger populated states to begin with. But we were seeing it pretty much everywhere by the late 80s. And it's only grown since that time. I think Medicare was attracted to having managed care be a piece of the Medicare options because of the cost control factor and hoping that it would, as you said, reduce the money that Medicare would spend per member. And that's how we got to where we are today.
So what is the business model that attracted commercial payers to the Medicare business? So CMS's, their draw was to try to reduce cost or the pace of the increase in cost. What was the hook that drew the payers to Medicare?
Well, I'm speculating because I don't have any, health insurance experience, but simply stated, I think they believed with their cost controls, the amount of money that they were going to get on a capitated basis, meaning Medicare gives them a premium, that's per member per month. And then, of course, there's some factors involving severity of illness where they can get additional payments. I believe the payers believe that they, could do that, negotiating pricing with the providers and applying cost controls and make a profit, which is, the business they're in. I also speculate that at the time Part C was put into effect, which was during the first President Bush's administration, there was a lot of talk about universal access in the country. We're one of the few developed countries that doesn't have a model that provides universal access for people to get health care. And because Medicare, which also administers the federal part of the Medicaid program, to the extent that Medicare and Medicaid are often as much as 50% of a provider's payer mix, meaning half of all the money that comes in a hospital's door is coming from Medicare, Medicaid already. That the thought was if at some point we get universal access, it's going to have to be through Medicare or Medicaid or some combination of the two. And then you have the question of what are all the health insurance companies going to do? That's a huge part of the economy. And so I think it was also a way to provide for them to have a place if the system moves in that direction.
So then thinking way back to the beginnings of Medicare Advantage, what issues were encountered early on in the program?
Probably the biggest one to talk about is pre-authorization. Most managed care contracts have some kind of pre-authorization requirement. It may be called pre-authorization sometimes called pre-certification or pre-cert. Sometimes it's just called a notification requirement. Sometimes it's actually a determination as to whether or not the proposed treatment is medically necessary according to the health plan or the managed care company. Sometimes it's just a mere notification requirement. There's no medical necessity determination. It's just they require notification. Medicare or straight Medicare has no pre-authorization requirements at all. So as long as you're seeking a covered service by Medicare, or you're going to a provider who has signed conditions of participation with Medicare, you just go and see that provider and get whatever treatment that they, suggest or provide. And so the pre-authorization was an issue. And then the second issue is that it wasn't clear under the Part C statute or the regs what parts of Medicare the plans had to comply with. So, for example, Medicare has a variety of diagnoses that they put on what's called an inpatient only list, which means patients can only receive those services for those DRGs on an inpatient basis. And so that's where some of the Medicare Advantage companies don't follow the inpatient only rule and might decide that, a certain treatment could be handled outpatient. So between the pre-authorization rule and some of these other items that are regulations or rules that Medicare has, it's not clear that Medicare Advantage was required to follow them. And so it was hard for providers to know if those Medicare requirements were enforceable on the managed care plans.
This brought on friction between providers and Medicare Part C payers.
Yes.
And that friction has been growing now over the years. So did this lead to denials of claims? And like you said, the providers were paying more attention to, well, here's what the Part C payers are going to pay us for our services, and less attention to clauses in the contract regarding these pre-authorizations and other things that they weren't used to with traditional Medicare in dealing with CMS directly.
So if you have all these ways in a contract for claims to be denied, and I'm not suggesting that no denials are appropriate, providers make mistakes too, and there's issues, and medical necessity is not a black and white determination. So even physicians with all the best intents can disagree over whether a certain treatment or service wasn't medically necessary. But if you have all these provisions in the contract that allow for these high rates of denial, then there is no amount of rate negotiation you can do to overcome that, because you're just going to lose the money on the back end.
Yeah, as a prior CFO, the whole concept of managed care, it sounds good to me. I mean, it sounds like this is the way things should be done. I mean, there should be a payer that is looking very closely at each case, at each incidence of the provision of care, and determining whether or not, that is medically necessary, or however they determine the necessity, and would push back on the cost. And that in and of itself should start to bring the cost down. And I think that was the underlying concept to begin with managed care, and which turned now into Medicare Part C when we're dealing with Medicare and managed care. But today we're seeing providers dropping managed Medicare Advantage plans for some of the reasons that you state. But I mean, it seems like literally every week I'm reading about another provider or group of providers dropping Medicare Part C plans, meaning they don't accept that insurance if a patient walks in because of this friction. Is that what you're seeing has been building over the years, and now we've reached this inflection point where so many Medicare recipients or beneficiaries are covered by Medicare Part C as opposed to traditional Medicare, that the providers are not able to deal with some of these provisions anymore?
Absolutely. I mean, the current stats is half of Medicare beneficiaries are in a Medicare Advantage plan, and half are in straight Medicare. And not only are you seeing more and more providers drop certain plans, but you're also starting to see plans starting to pull out of markets. The system is getting frayed on both ends. The providers don't feel like they're getting fairly compensated, and the plans are seeing where they're not making adequate profit to stay in the market. And so I notice more and more of those on a daily basis.
Yeah, I'm also seeing Medicare Advantage plans, like you said, Lawrence, dropping out of coverage in certain locations, dropping their plans. A lot of the big insurance companies have actually, in their latest financial guidance, they've reduced their guidance due to the fact that the Medicare Advantage membership is either declining or not picking up as they thought it would, which is creating an issue on the payer side as well. So what has CMS's reaction been to this provider complaints around the Medicare Advantage plans, specifically around their behavior?
Well, just this year, they promulgated a new rule. And the rule is fairly extensive, and it actually tries to address some of these issues we've discussed. It's addressed the fact that medical necessity denials have to be pretty much using the same criteria, and coverage requirements that Medicare uses. It does indicate in some ways where, Medicare, rules and regulations should be applicable in managed care. It's a fairly extensive rule. And of course, you don't really know how it's going to turn out in the marketplace until it's tested, either in dispute resolution with the plans or in, Medicare appeals. One of the things that complicates it a little bit is almost every managed care contract has both a requirement for alternative dispute resolution, meaning mediation and arbitration, and confidentiality clauses. So whereas when you file suit and litigate a matter, at some point, the court has the ability to designate whether that decision will be what's called a published decision or not. And if it's a published decision, any lawyer from around the country can, in doing their research, find that decision. That's how we get precedents. And so one of the downsides to arbitration is that there is no publication of those decisions. They're confidential. So I couldn't tell you on a particular issue if there's been no cases around the country or 1,000 cases around the country. And so that confidentiality, which reduces, the publication and the making of the knowledge of the issues in the case and the resolution public, makes it more difficult to say whether this regulation or a prior regulation is helping or not helping.
This episode is brought to you by the Center for Healthcare Leadership and Management, the definitive resource for healthcare management education in North Texas. The center is based in the Naveen Jindal School of Management at the University of Texas at Dallas. It plays a unique role in training the next generation of healthcare leaders to meet local, regional, and national demands. The Jindal School uses its strengths in accounting, administration, finance, marketing, and information systems to educate highly qualified personnel for healthcare administration and executive leadership positions. The center is home to 7 healthcare leadership and management programs, including undergraduate and graduate programs, as well as executive programs for physicians and working professionals. For more information, visit us online at jindal.utdallas.edu/healthcare.
What about AI and the use of AI by payers in basing their care decisions or allegedly basing their care decisions? Has CMS weighed in on that at all that you know of?
They have not, but we're starting to hear from clients who are concerned about reviews that encompass medical necessity that are done by computer program or algorithm or AI. And so the provider's concern is there's numerous things in a medical record that could impact on whether a claim is payable or not payable, medically necessary or not medically necessary. And when a computer does that from the bill alone, without reference to the medical record, their concern is that things are missed, social services notes, nursing notes, a variety of things are not considered that might impact the level of care and whether it's medically necessary or not. So there's a huge concern in the marketplace about the practicalities of whether the AI is ready to do this now, especially if it's not actually reviewing a medical record.
So, I guess in summary, we've got issues both on the payer and the provider side in the Medicare Advantage world right now. The providers, like you talked about, they've got an administrative burden with the payers with managed care through claims denials, pre-authorization requests, general slow paying. So they're starting to drop Medicare Advantage plans, not accepting those plans in their facilities. And on the payer side, Medicare Advantage is losing its profitability over the last, 2 decades. Medicare Advantage plans have been growing significantly for the providers that choose to offer those plans. And because of the growing aging population of those over 65, the baby boomers coming into that age set, it's been a pretty lucrative market for payers that are in that space, pretty profitable. And now we've got CMS starting to push back on those payers on rates that they're charging and medical reviews that they're doing on the patients that set that per member per month rate that capitated rate you talked about earlier. So we've got some problems on the payers front with payers dropping Medicare Advantage plans from their portfolios, providers dropping Medicare Advantage plans from what they accept. What are you seeing on the horizon in the Medicare Advantage plan space? What do you see in the evolution? Anything that you think might be coming up there?
I'm hoping this regulation from Medicare helps. There definitely needs to be a little bit more clarity on the regulatory side so that both providers and payers know what's expected, because then plans, payers can incorporate that into their pricing model, negotiations with hospitals, premium setting, services offered, et cetera. And providers have a better idea of what's enforceable. But without Medicare getting more active in the space and setting the ground rules, personally, I think we're in for another few more years of providers dropping plans and payers pulling out of markets.
Yeah, I'm thinking the same thing. And then, that will eventually lead to the necessity for, tighter rules from CMS or some greater clarification. But, right now we're at an inflection point, I think, in the whole Medicare Advantage business model for both payers and providers. And I guess we'll just have to wait to see what the next move is, what the next chess piece move is in this game to find out what's going to happen.
And I'd like to see CMS do a little more regulation on the marketing of the plans as well. I mean, it's just my personal experience, but I became eligible for Medicare 2 years ago, and I thought I had a leg up since I'm in the business and have done it all my life. And I had to talk to 4 different brokers. All 4 had incorrect information. And the only way I got a good broker is I called a law school classmate who had been the compliance officer for a large health insurer. And she put me in charge with a customer service person who gave me somebody that knew what they were talking about.
Well, I mean, what you need to do is watch some of those cable stations that play the old 70s and 60s show reruns. And just about every other commercial on those is for a Medicare Advantage plan, or a dual coverage Medicare Medicaid plan. And these are some of the cheesiest commercials you'll ever see. And I actually show them to some of my classes when I'm teaching Medicare and Medicaid stuff, just to show them the lengths that some of these insurance companies, and these commercials are typically run by the brokers, that are trying to get you to sign up with them so that then they can help you find a Medicare Advantage plan. But there's certainly no shortage of them. So I think I'm with you on that there should be some sort of a regulation on that, because some of the commercials are just crazy.
The first broker I talked to, I started by saying, I don't want Medicare Advantage. I want straight Medicare. I want a supplement. I want a Plan D for prescription drugs. He sent me several different Medicare Advantage plans. And I said, I don't want any of these. And he said, why not? And I said, because they don't pay the providers. I want somebody who's actually going to pay the people who are treating me. And he said, oh no, they have to pay. That's the law. They pay all the claims. And I said, you should come sit in my office and see our files. And it kind of got worse from there. But let me tell you just one horror story I like to tell people. I had a couple come to see me a few years ago, and they had straight Medicare. And during open enrollment period, their story is, I didn't verify this, but their story is they were visited by a broker who they thought was selling them a better supplement, but actually put them into a Medicare Advantage plan. And then right after, he was diagnosed with brain cancer. And so he went to the local oncologist, who was one of the area's specialists in brain cancer, who said to him, the kind of tumor you have, there's really only one doctor who works with this tumor day in and day out, and he's at Duke. And my advice to you is you go to Duke and get treated by this guy. So he called, he made the appointment, he got an appointment, they called him back, and they said, you're in the XYZ Medicare Advantage plan, and they wouldn't pre-authorize you coming here, so we can't see you. So they came to see me to get advice, and what they decided to do was to go to Medicare and complain that they didn't know what they were buying. They wanted to go back to straight Medicare, which worked for them, but took 45 days. And so it delayed his treatment by 2 months. And so he died shortly thereafter.
But you were able to get with Medicare and have them undo?
No, my advice was to appeal the denied pre-authorization, because you could argue that it was urgent and that required them to move faster. And that would have been the way I would have handled it, because there was no guarantee that, they made the decision open enrollment. Medicare could have just as well said, wait till next October. But they decided not to have us handle it. She did it herself. She got Medicare to change. But it took a while.
Yeah. So I guess we should say, based on that, just backtrack a little bit. I mean, traditional Medicare, like you said, you can basically go to any doctor that you want that's, a registered Medicare with Medicare, or any provider that you want to. But the attraction to Medicare Advantage, why would you ever sign up for Medicare Advantage, is that a lot of those plans offer things that traditional Medicare doesn't, like vision, hearing,
dental, gym memberships, grocery assistance. Plus, being on straight Medicare, there's income limits. So if you get Medicare, you're still working, you earn above a certain amount, I have to pay a Part B premium, right? So I pay the Part B premium, then I pay a supplement premium, and I pay for my Part D. Now that's half of what I was paying when I just had regular group insurance. It's still a considerable amount. Whereas in Medicare Advantage, you could very well be in a circumstance where you're essentially getting all that in one bundle, plus those additional services, and you're not paying anything.
Yeah. And so when you get, it sounds like you're getting something for nothing, right? So what do 65 and overs need? Just about all of us, right? We need vision, we need hearing, we need dental, because all those things are getting old and not working quite right. And what doesn't traditional Medicare cover those three things?
Right.
And so most Medicare Advantage plans will cover those three things, as well as whatever traditional Medicare covers. But at what cost? The cost is the restrictions that the Medicare Advantage plan puts on the providers that the recipient, that the Medicare beneficiary can go to if they're in the Medicare Part C plan, like you mentioned with your story there about that couple.
Here's the other piece of that trap. When you turn 65, you have a short 3-month window to sign up for Part A and Part B. Part A covers hospital charges. Part B covers, doctors and, chiropractors and physical therapists and all of the individual providers. If you don't sign up for Part B at that time and you decide to sign up for it later, it costs more, and it costs more for the rest of your life. The second thing is if you decide to get a Medicare supplement is an insurance policy sold by a private insurance company that pays for things that Medicare doesn't pay for. So copays, deductibles, etc. During that 3-month period, there's no underwriting for that coverage, meaning you're 65 years old, you're going to pick whichever one of the Medicare supplement plans you want. They're not going to look at your health history or status. It's just X charge. And then over time, the cost gradually goes up. If you have Medicare Advantage for a year, 2 years, 10 years, and you decide, no, I'm going back to straight Medicare, your Part B is going to be more expensive. And now they can underwrite the Medicare supplement. So if you have more health problems, if you have heart disease, you have diabetes, it may be unaffordable. So when they talk about open enrollment, it's really not that you can go back to straight Medicare if you want to, because by the time you decide to, it may actually be unaffordable.
So if we haven't scared the listeners enough about this, they can do a little bit more research, but it is a complicated area. At a time in most people's lives when they're just not into complicated.
No, and it's very complicated. It's crazy.
Yeah. So Dale, as an attorney that just recently entered the Medicare Advantage sort of market, if you will, what are your observations? What are you seeing?
Yeah, so I've been working with Lawrence for about 10 months now. And so I've gotten kind of my toes wet, I guess, in this market. And, kind of the things that I'm noticing is that it's a more difficult situation for providers. We represent providers in terms of, traditional commercial insurance or traditional Medicare. You're seeing, issues in terms of, slower processes when it comes to appeals, when it comes to decisions on claims. You have some issues with maybe some prior authorizations, denials, and just providers and payers not being on the same page a lot of the time when it comes to those issues. So the big thing is just there's more issues than just what you're seeing in traditional Medicare, traditional commercial insurance, which frustrates providers. It probably frustrates payers as well, but that added frustration just makes it where it's harder to work together on both sides, which is kind of what I've seen be the biggest issue, is just this frustration in working together so far.
Yeah, I mean, that's a great observation. You think of the provider market just in general, it's different than most industries in our country. I mean, a typical provider, their days in accounts receivable, and I'll explain that in a second, is somewhere between 30 and 70 days, which means that a provider could start, let's say they start business today. They hang their shingle, they start business today, they start seeing patients. They don't see any payment, any significant payment for the work that they're performing for those patients for 30 to 70 days. So imagine starting a business, having to pay your staff, having to pay your rent, and treating customers, but not getting paid by that first customer for 30 to 70 days. So this is why getting paid is so important to providers. And when you've got companies, like in this case, we're talking about insurance payers, Medicare Advantage in particular, that are holding payment or denying payment and making you resubmit your invoice again, your claim again, that's just holding up your cash even longer. And it's hard to keep a business going with that sort of cash flow. And that's what makes these issues that providers are facing with Medicare Advantage plans so tricky for the providers.
Yeah, and what you want, I mean, at the end of the day, from providers, is you want them to be focused on treating patients, not whether they're going to get paid or not. And so, when you're adding this layer to it, that they're, worried whether they're going to be able to get paid down the line. And like you're saying, 30, 70, 90 days, it takes some of that focus off of the main goal for these providers, which should be treating the patients they have.
It's a whole layer of administration that's added to the provider that really shouldn't be there. So you talk about, why does the U.S. spend far more per capita as a percentage of gross domestic product than any other developed country? This is one of the reasons. So, gentlemen, thank you for being with us today and helping us try to make sense out of this unique and often misunderstood, and perhaps still misunderstood, part of our Medicare system. I'm sure we will want to chat with you guys again in the future as this area continues to no doubt evolve.
Yes, thank you for having us.
Thank you so much for having us. It was a blast.
Thanks for listening to the Business of Healthcare podcast. To learn more about the Center for Healthcare Leadership and Management and the healthcare management business degrees and certificates available to seasoned clinicians, master's students, and undergrads through the University of Texas at Dallas, go to jindal.utdallas.edu/healthcare.